Hello, everyone, and welcome to PerfWeb 34, Day 2. We have a very exciting and I think timely and provocative discussion program for you today, especially in light of everything that's going on with the COVID-19. But you'll see all of the parallels, I think, as we move forward. I want to go through the opening remarks very quickly if I can. I don't want to spend a lot of time on this. You got to thank our sponsors, please. Without them, we have absolutely nothing. We got to keep these lights on, and especially now with the squeeze of what's going on financially in this country, we need them more than ever. So really need you to consider thanking them, clicking on their sites and looking at what products they have that may help you in your practices. As you know, we're on all social media platforms. It's very important that you like us, follow us, share us, and give us the thumbs up, subscribe to our YouTube channel, and ask for notifications with the notification bell, please. Check out our websites at perfweb.us and perfusioneducation.com. Those sites have tremendous resources for you to earn all of your required ABCP CEU from one source so that you don't have to go anywhere. You know, it's more convenient, it's more affordable, and it's high quality education for you guys, covering a whole host of different topics with real content experts. We have a call-in number today. I really need you guys to write this down, 832-239-5358. When you see that sign, the phone lines will be open and you can ask questions live on the air. Of course, you can always chat those questions via YouTube or via Messenger and Facebook, and also on Twitter. We're monitoring all three of those platforms right now, and I think LinkedIn as well. So any questions that you have, please go ahead and we'd love for you to call in, be a part of the conversation. Okay, I'm going to go straight into introducing what I consider to be probably one of our most incredible faculties that we've had all year. We've had a lot of good ones too. But to my right here in the studio with me is Dr. David Platt. Dr. Platt has a PhD in carbohydrate chemistry from Weizmann Institute of Science from Tel Aviv in Israel. It's in Tel Aviv, right?
Yes.
In Tel Aviv, yeah.
Yes.
And completed his postdoctoral work at Wayne State University in Michigan. He is a pioneer in designing drugs derived from copolymers. He has over 30 years of experience in drug development with over 30 patents, authored 10 journal articles, completed 2 textbooks, and I'm going to show you those books right here, which you can get from Amazon. I highly recommend it for those scientists out there. Has been the CEO of 5 public companies, 3 of which were on NASDAQ, and conducted over 30 clinical trials. He was the very first to combine chemotherapy with copolymer to target cancer, which radically improved the safety profile of the treatments. He coined the name galectin, which we're going to talk a lot about, and was the first to publish in a field of research that now produces over 300 peer-reviewed articles annually.
3,000.
His 3,000. I'm sorry, this is
annually is 300.
300 annually, right, but total of 3,000. Thank you. Well, I appreciate that. His life's work is embodied in his latest invention called BXT25, which is an oxygen transport delivery drug that is 5,000 times smaller than a red blood cell and is capable of treating stroke, ARDS, and other diseases that have an element of hypoxia associated with the disease. Also coming to us, if we can bring Dr. Majewski up. Hey, Dr. Majewski. Dr. Majewski is
Hello.
A professor and research and does research and activates Dr. Majewski is a PhD and professor emeritus at Bar-Ilan University in Israel, doing research and teaching activities since 1965. Now, you don't look old enough to be teaching since 1965, Dr. Majewski. And just if you could you move to your left 2 inches?
Pardon?
Move to your left 2 inches. Oh, that was
Like
about,
this?
yeah, a little less. Halfway. To the right now. Nope, the other way. To the right. Right there. Perfect.
Okay.
Now you're dead center in the screen. Thank you so much.
Okay.
His main field of research is brain and other organ physiology related to oxygen supply and metabolism in vivo. Professor Majewski has published more than 240 articles, as well as a book published in 2015 by Springer. Professor Majewski is the world leader in monitoring in vivo of physiological activities in the brain and other organs of experimental animals, as well as in human patients. He has developed many experimental models in animals related to changes in oxygen supply from hypoxia and from ischemia and its effect on mitochondrial function. He has served as a consultant to various pharmaceutical companies in evaluating efficacy and safety of new developed drugs. Professor Majewski was the chief scientist of 2 medical device companies that developed and attained FDA clearance for those particular products. Energy metabolism and function of the brain and other tissues in vivo under various pathophysiological condition is his main field of research since he started his postdoctorate training with Professor Brighton Chance at the University of Pennsylvania in 1972. During almost 50 years of activity, he was able to accomplish a large number of goals that have been very significant, impacting on the understanding of physiological processes in the brain and other organs evaluated under in vivo conditions. The vision was to develop experimental approaches and tools that will enable us to study various physiological processes in experimental animals and at the same time will be ready for clinical applications. His philosophy has been to contribute significantly to society's health and well-being after enabling and funding his research activities during the last 5 decades. In addition to the large number of studies in experimental animals, he was able to translate the methodology into a platform of medical devices that will affect in the near future patients' outcomes in various clinical conditions. Just some of the highlights for you, Dr. Majewski, if I could bring it up, please. You've been the developer of the first fiber optic-based fluorometer reflectometer for NADH monitoring in anesthetized and unanesthetized animals. You developed a multi-parametric monitoring system for evaluating mitochondrial function and microcirculatory blood flow, something we've actually talked about. So I've got some questions about the microcirculatory blood flow and side stream dark field imaging. I'm somewhat curious on your opinion on that. And development of a new tissue vitality index, in quotes, vitality index, based on a large amount of experimental results and adopting of various modeling approaches. So you've done a lot in your 50 years, and Dr. Platt, you have done a lot in your 30 plus years. And I do, if I can you zoom in on these 2 books? I'll put them up right here. And I highly recommend you guys. I'm sorry, Dr. Majewski, I don't have your book, but these are 2 of Dr. Platt's
I will show it to
books.
you in a second.
Please, here, he's going to get it for you. But take a look at this. You can get these on Amazon. I highly recommend you get them and read them. They're very interesting, very provocative, very science-based. And there is Dr. Majewski's book. I highly recommend that as well. I need to get a copy for myself. So these are very interesting topics that do a lot of interesting things, especially in the field. So we're going to start off with the MDX-Viewer. Then we're going to talk about the nanomolecule and oxygen transport, oxygen delivery. And we're going to do the program today in 3 parts. Dr. Majewski first, followed by some discussion. Dr. Platt second, followed by more discussion. And then a combined discussion about everything we discussed. Then we're going to split the program. We're going to take a short break, and we're going to come back, and we're going to discuss some investment opportunities for both the MDX-Viewer and also the nanoparticle, so that everybody out there who's watching the program that may have an interest in this can do it. But we are going to separate it out from the science portion of it and the evidence-based medicine part of it, and then separate it to that. And we'll bring Mike Seek in as well to talk about some of those opportunities. So with that said, Dr. Majewski, we have your slides. They are up. If when you're ready to go to the next slide, just say next slide and I will switch it for you.
Okay. Next slide, you can start, please. Okay, next slide. This is just the introductory one.
Mm-hmm.
I don't see your screen so clearly. Okay.
Here, we'll fix that for you, Dr. Majewski.
Okay, that's better.
Mm-hmm.
Okay, thank you.
Here we go. MDX-Viewer, the third vital sign.
Right. If you want to get to see the device itself, actually, you can see it behind me. Just look at behind me. There is the device is staying on the stage over there, so you can see.
Yes, I see it.
Okay.
We see it. Can you make his screen bigger just to show him?
The only thing I can do, I think, to take the camera closer to the device.
There, we did it right there. Now we can see it. It's full screen.
Oh, okay.
And you're coming to us from Israel, right?
Yeah, I am now in Israel.
So it's about 10 o'clock at night there?
Yeah, now it's 10 o'clock.
We thank you very much for staying up so late to be with us today. Okay, so go ahead. So we'll go to the next slide and we're ready to go whenever you are, sir.
Yeah. Okay, just to show an example, what is the need in diagnostic of patient is ARDS, which is one of the main clinical terrible situation in the intensive care unit and other department of clinical daily life. And this is the ARDS, which is really a problem of the respiratory system. And there is not enough oxygen to supply to this patient because the lung is not working well. And actually today we face it when we are talking about the corona. So the main issue is to try to solve the problem and to evaluate the efficacy of oxygen delivery to the patient under this severe situation. Next slide, please. Okay, today, what the current measuring devices in the operation room and ICU and other departments in clinical daily life is either to use the pulse oximeter to measure the oxygenation of the blood, or measure the blood pressure that you see in the center, or to listen to the heart rate, measure temperature, and in the intensive care unit, of course, you have more parameters that could be monitored, but all of them are providing information about the systemic system, namely the cardiovascular system and the respiratory system. None of the parameters that are measured today are telling the physician any information about the tissue level physiology and biochemistry, which is the most important information that need for daily treatment of the patient. Next slide, please. As an example, you can see here, this is a brain of a patient that if you have a probe, you can put the probe on the brain and the device will show you 4 different parameters that I will go in more details in a minute. You see it on the right-hand side of the figure. I just will mention it. We measure the metabolic state of the mitochondria regarding the oxygenation of the mitochondria and the cell, and we measure the blood oxygenation in the microcirculation. And the third parameter, the blue one, is the tissue blood flow, and the fourth one, the yellow, is the tissue blood volume. All these 4 parameters can be monitored by the MDX-Viewer simultaneously from the same area of the tissue. So you can correlate between the 4 parameters and understand very well the physiological and pathological or pathophysiological events developed in the patient along the time in real time, second by second. Next slide, please. Now, the device that you see on the right-hand side, the MDX, that I showed you before in my room here, is measuring 4 parameters that you see in part E. The technology is an optical approach. We are using optical probe, using different light waves, different color of light. We excite the tissue, and then we can collect the light scattered back from the tissue and analyze it and obtain the 4 different parameters in real time continuously. So you can see in part B, you can see the main parts of the device that I will not go to details, it's more technical. Part C show you one of the main applications that we can use the device to monitor patient in the operation room and in the ICU. And here we want to use a very well-known pathological or pathophysiological event that develop in a patient when oxygen is not, the balance of oxygen in the body is negative, namely the supply of oxygen, like in hypoxia or ischemia, the amount of oxygen delivered to the brain or to the organs in general, to the body, is not enough. And then the body use the adrenaline to shift blood from the less vital organ to the more vital organ, namely the brain and the heart are protected under these conditions, getting more blood, and the less vital organs like the skin, it can be the intestinal wall, and so on, they get much less blood. So if you put the probe, our probe, that can be embedded, as you can see in part C and D, it's a Foley catheter, urine Foley catheter that you can see it in outside the body, and here in C, you can see it inside the body. We measure the 4 parameters simultaneously from the wall of the urethra. Now, once you measure this parameter from the urethra, you are going to see an early warning signal coming from the body of the patient telling you that there is a problem in oxygen supply to the body as a system. Therefore, the body shifts more blood from the less vital organ to the more vital organ, the brain. In order to preserve the organism, you need the heart and the brain to continue to work, even you can create damage to the less vital organs. So this is what you can see here, the basic concept. So when you put the Foley catheter in the patient, you can measure and you get 4 parameters that you see in part E that I mentioned before, and this tell you about the tissue level physiological parameters that telling you the oxygen balance in the microcirculation and the cellular compartment, namely the cells. In part F, you can see in the future we will embed in F and G, we'll have 2 more parameters that will be added to the 4 parameters that we measure with the Foley catheter. We will embed 2 more probes into the Foley catheter, so we'll get some systemic measurement via the Foley catheter from the same location in the urethra. Next slide, please. So actually, we are want to know what is the level of oxygen that is available in different compartments of the body. So if we start in air, the atmospheric air, we have about 160 millimeters of oxygen, partial pressure. In the respiratory system is about the same. In the cardiovascular system, it goes down to 95. You can see it on the second row. And then you have in the tissue microcirculation is going to 20, 30. And intracellularly, it's about 1 and 2 millimeters of mercury of oxygen. So the level in the cell is very, very low. Therefore, if there is a shortage of oxygen in the other system, like the cardiovascular and the respiratory system, the cellular area will be affected tremendously immediately when there is a shortage of oxygen to the patient. Therefore, we are looking on an area in the body that is very sensitive to the oxygen availability any second in the life of the patient. Now, on the right-hand side, you can see here what I already mentioned, that you have the systemic vital signs that's used today, and we are going to add the lower part of the scheme that you see the microcirculatory oxygen supply, and you have the tissue oxygen balance, which can be measured by the mitochondrial NADH redoxate, which is the enzyme that helps to create the ATP in the mitochondria in order to supply the ATP as a source for energy for the activity of the body. Next slide, please. Okay. Now you can see the details of the 4 different parameters. I will go very shortly, not too many details, but on the left-hand side, you can see the mitochondrial function measured by the fluorescence of one of the enzymes, the key enzymes in the respiratory chain of the mitochondria. And on the right-hand side, the upper part is the tissue blood flow. In the lower part, you see on the left side the blood oxygenation and the tissue reflectance on the right-hand side lower. Now, the blood oxygenation that you will see here is not the same as the pulse oximeter is measuring in the patient today. We are looking here on the oxygenation at the level of the microcirculation in the capillaries area and the very small arterioles, which is much lower than what is available in the large arteries. Therefore, the measurement of this parameter is important to add to the battery of parameters that we measure together. So actually, by using these 4 parameters, all of them are optical techniques, we can get a very good picture of what happened in the microcirculation and in the cellular compartment at the same time. So we can now move to the next slide. Here you can see the balance, what we are calling a tissue oxygen balance between oxygen supply and oxygen demand. Normally, there is a very small reservoir of oxygen in the tissues because the tissues are dependent all the time on continuous supply of oxygen via the circulatory system and the respiratory system. Therefore, the reserves in the tissue is very low. Once you stop the supply, you get a shortage of oxygen in a few seconds, and then you start to go into a problem of oxygen supply. So we want to know all the time the balance between the supply and the demand. So if the demand is going up by activation, like the muscle, if the muscle is working harder, you want to give more oxygen, you will accelerate and give more supply. But if the supply is limited, then if you increase the demand without changing the supply, the balance will become negative. And if it's negative, then the tissue go to hypoxia and lack of oxygen and all the damages that can create to the tissue by shortage of oxygen. Therefore, it's very important to keep the balance between oxygen supply and oxygen demand that actually enable to produce enough ATP that you can see here in the center by the mitochondria. And most of the ATP that produced in the cell is dependent on the oxygen availability and the mitochondrial function. Next slide, please. Okay, here you can see the Foley catheter that I showed you already before, and the technology a little bit in more details, but written here. You can see here the power supply of the system and the bedside unit that is in behind me. You saw it before. What we have different light sources that it's embedded in a light source unit, and all these wavelengths that we have to excite the tissue with are coming from this unit. Then the light is going via the Foley catheter down to the urethra wall, and the light is coming back in fiber optic channel, another channel in the fiber optic probe that you see here, and it's collected to the detection unit, and the detection unit differentiate between the 4 parameters and calibrate it in relative units, and we can see it display on the device in real time. Next slide, please. Now, here you can see the next generation that we actually already start to work on it, and we publish on it a few papers already. And this is to translate the real-time data that we collect from the patient using the MDX device, and to calculate a more easier parameter for the physician to interpret the physiological situation of the patient. Namely, we take the 4 parameters that are monitored by the MDX-Viewer, and we integrate it into what we call the tissue metabolic score, the TMS. The tissue metabolic score is actually a mathematical calculation based on thousands of animals that we used in the past, and also about using mathematical models. We found a way to calculate the 4 parameters to a single sort of a score that the physician can use. Once the score is going up, it means that the oxygen supply, oxygen balance is okay. If it's going down, it means that there is a shortage of oxygen and the balance is negative, and the patient will go into a pathological state development. So that you can see on the left side of the slide. On the right-hand side of the slide, you can see the systemic patient monitoring system that already exists, and then you can calculate from these parameters that monitor from the patient, you can calculate also a sort of an index or a score, and then later on to combine the 2 scores together into a machine learning device or system expert system, and get sort of a signal that will tell the physician when the patient become ischemic or hypoxic. Namely, once there is a shortage of oxygen to the body at the system, it means that it will take few more seconds or minutes to get damage to the brain and to the heart. So by looking on the urethra wall via the Foley catheter, we can get the information earlier than it will appear in the brain, and we can, as a physician, can make an action to protect the patient by a different kind of procedure, for example, giving more oxygen or injecting a drug to increase blood pressure or whatever is needed. So this kind of early warning signal, this is a dream that actually will get through the clinical daily work if the device will be sitting next to each patient that need real-time monitoring of the oxygenation of the body of this patient, like in the ARDS or other kind of situation, severe situation, that oxygen supply to the body and the system is disturbed by different kind of pathological states. Okay. And actually, this slide is too many details to go step by step, but this shows you, in general, that the MDX has a very high value as compared to what today available in the market, namely medical devices that can compete with the MDX. Actually, if you look on the right-hand side, where the MDX is compared to all the parameters that show in the second and third and fourth row, all of them have some green check and some X, red X, But if you look on the ICU device or the tissue metabolic score, you can see that all of the parameters that we are measuring, we provide information about the microcirculation together with the intracellular compartment, the mitochondria. So all is checked with green. So this is the main advantage of the MDX over all other kind of devices available in the market. All of them are based on one or two parameters. We are the only device, we have the only device that can measure 4 different parameters together simultaneously in real time coming from the same tissue volume. Therefore, the value of this kind of parameter is tremendous for clinical daily diagnostic and follow-up of efficacy of either drug giving, like to giving the BXT-25 to provide more oxygen, or to give any other drug to the patient. I think we are almost, this is just a sort of potential application. You can see that mitochondrial function is so basic in the daily life of each tissue, each cell of the body. Therefore, if you can monitor the mitochondrial function in real time, you can actually provide information that will save many lives and improve the prognostic of each of the patient that comes through different clinical situations. I think that's the last slide, right? Okay. Yeah, this one.
That's the last slide.
That's the last slide?
Yeah.
Okay, very good.
That's the last slide.
That show what mitochondria are measuring oxygen,
Yes,
different disease indication.
yes, yes. That was this slide here, right. So very good. Okay, so we want to go to full screen now? Yeah, very good. Thank you so much, Dr. Majewski. That was intriguing and very interesting, and I would say it makes perfectly good sense to me, and I believe
The device,
it's
by
gonna-
the way, was approved by the FDA.
it's going to make so it is approved by
It's
the
approved
FDA.
by the FDA.
So, because it makes a lot of sense. I wanted to ask you, I've got a series of questions that I want to ask you about this. Simplistically, if I can, and Dr. Platt, you feel free to add into this as well. You essentially get either a score or an index that is positive or negative. You either have sufficient supply or maybe even luxurious supply, or you don't, and it's negative. Is that sort of distilling it down to what the tissue oxygenation score is?
Yeah, it's not the supply, but it's the balance between the supply and the demand.
Balance. Yes, supply versus demand, essentially.
Right.
So what you're saying is that this is going to be a real-time, second-by-second window into the homeostasis of the patient in regards to their oxygen supply-demand ratio, and much faster than waiting for a lab where you're doing a surrogate, a lactate to infer that you have
Right.
some type of ischemia going on somewhere.
Yeah, lactate, for example, that you mentioned, the lactate delay in responding is it can take minutes, maybe 10, 15, 20 minutes before you start to see a real change in lactate. Now, lactate is a parameter that's not related only to the oxygen supply, but it's also related to the balance in the body of all the hematological situation of the patient. So it's not so specific. We are looking here with the MDX, we are looking on very specific parameters that related to the oxygen supply and demand directly. Therefore, we have compared the lactate, and always the lactate is delaying in response by 10, 15, 20 minutes after we can see the change with our device.
Very good. So, I have to ask, just to be sure, specific. So the device does not necessarily selectively measure. It's very global. So if there's an issue, you have to identify where that ischemia is coming from. Is that correct? Unless it's it's global, general.
Yeah, it really depends. We didn't go into it in the presentation, but it really depends where you put the probe. For example, if you want to measure a patient in a neurosurgical operation procedure, during the operation, you can put the probe, and we have it on one slide. We show the probe on the brain.
Yes.
If you put the probe on the brain directly, you will measure exactly what happened in the brain and not in the body.
Gotcha.
But if you put it in the urethra using the Foley catheter, the picture will represent the body as a system in addition to the urethra, because the urethra is a less vital organ, is a very early responder before the brain and the heart that are protected in the initial state of the pathological development. Therefore, it depends where you put the device.
That makes perfectly good sense to me. I completely understand that. Now, you clearly know a lot, and I think are recognized in the field of hypoxemia. Can you maybe just give us a little bit of more awareness of what you've been doing with your life to become recognized in this field?
Well, actually, when I started to measure the mitochondrial function, that was the one parameter that I measured at the time. And we look on the mitochondrial function in real time, and that I did during my postdoc period. But then I found that the physiological systems are so complicated that if you measure one parameter or two parameters from the subject, from the tissue in the animal or in the human, the information will be very, very limited in possibility to interpret the real pathological event. Mm. Namely, that if you use one parameter, the worst case that you can analyze any pathological state in the patient or in the animal. The more parameters that you add, the better the diagnostic tool you have in hand. Namely, that we start with one, and then we add 2 and 3 and 4. We came in the brain to measure 8 parameters in a patient in the intensive care unit. Mm-hmm. So we have a probe that was sitting on the brain of a patient in the ICU, the neurosurgical ICU, and we follow up this patient for 48 hours continuously, and we were able to indicate exactly what happened every minute, every 20 seconds, whatever time you want to select, but very short. And we found, for example, in this case of a patient in the ICU, the neurosurgical, that this patient that we were monitored, the brain became, after 24 hours, it became damaged. The brain became damaged because oxygen supply was not enough, and we saw the changes. But the definition of brain death was not clear yet to the physician. My device was able to show the event in the brain that indicate that this brain is now in a brain death situation. Mm-hmm. And it happened about 1 hour in this specific patient, 1 hour before the clinician were able to define and determine brain death of the patient. Mm-hmm. Now, why is it so important? First of all, you can take more measures to try to help the patient if you do it earlier. Secondly, if you want to have an organ donation from such a patient to use it in transplantation procedure, the earlier you know when the brain is dead and you can start the procedure for donation of the organ, you can get a better organ for the donation.
Oh, that's very true.
So there are many advantages to do this.
That's very true, because the heart actually suffers damage after brain death while we're waiting to explant it for the transplantation. That's very true. So I see a lot of opportunity in terms of the use of this type of technology. Have you explored the use of this device, the MDX device, in the urethra during the MDX-Viewer during cardiopulmonary bypass? Have you
Right.
used it for patients who are transitioning from, let's say, pulsatile perfusion to mechanical, their native circulation, to mechanical circulatory support through either the heart-lung machine or ECMO or something like that, where you now have continuous flow, no pulsatility, and a lot of hemodilution and a lot of microcirculatory derangements that occur? What's your experience with that that you could describe?
Yeah, in this kind of procedure of the cardiovascular operation, we have only 11 patients that we were able to do statistic analysis, because you know that each patient has different timing, and to get statistics you need large number of patients. But
Sure.
even with a small group of 11 patients, when we analyzed the data, we found something very clearly. I don't have it here on the presentation, but what happened is that once you start the operation and you open the chest of the patient, some patients start to respond immediately when you start the procedure, when you open the chest and you start with the surgery. So other patients may start the response in the urethra once you start to put him on the heart-lung machine. Now, what happened is normally in the group of the patients that we did, all of them show that during the operation, the blood flow to the urethra went down to almost zero. The mitochondria was dysfunctioning completely. It stopped working, the mitochondria, in the urethra. And it stays the same level of low flow and high or low mitochondrial function until the patient's chest was closed and sutures and come back to a normal activity after, of course, disconnecting him from the heart-lung machine and close of the chest. So we have now a very good idea that during a severe stress that the patient have, you will go into a situation that the urethra can give you the needed information. And now, why you need it further? Now, if you take the same patient from the operation room to the short ICU intensive care unit for the cardiovascular surgeries, you can follow up to 24 hours post-operative period and see whether the patient is stable, whether the patient is deteriorated suddenly, or if the patient come out from the operation not in a good situation, is he improving? Can you do something to help him to improve? Now, all is based on what you will see on the urethra parameter or the index.
That makes good sense to me. Dr. Platt, do you want to add to this? Because I have a couple of more questions, but I haven't heard from you yet, and I apologize. I get to asking questions and I can't stop.
That's very important for the reason we're here, because the Professor Majewski actually demonstrate the future, how you can measure and predict organ performance. That doesn't exist today.
Yes. So getting to that, how, Dr. Majewski, Dr. Platt, is this device commercially available? It's FDA approved, or the technology is, but is it available?
No.
And
We need.
if it's not, why not?
We need about. We calculate about 2 million to make it in production. So we are on the stage that we're looking for to collaborate with the company.
Hopefully some companies are watching, but we'll talk about that then after the broadcast. I didn't understand the reason that the only thing that's keeping this from actually being in the market
it's not money.
is money. Okay, so we can talk about that a little later. If you're a investor or you're a company representative that may be watching, please watch the end of the program. It's going to be important for you. So obviously heart surgery, any major surgery, trauma, would be appropriate. ICU sepsis, I would think. You know, I wanted to talk to you about side stream dark field imaging because I have done that. I have looked sublingually with the viewer, and when we go on the bypass machine, I can see with my own eyes the microcirculation and the capillary density essentially disappear. And so being, of course, it's important to see it. I think there are two different technologies, right? It would have been super if I could just stick something under the tongue, or in this case, something in the urethra, because essentially that ridge is just the capillary bed is very close to the surface. You can see it. It's the same thing.
This technology is the future in many ways. Imagine that in the form that it's now, we need to do beyond commercializing that and put it in ICU or any ambulance or any emergency or any situation that you want to know in advance that organ going to fail.
That you're having an oxygen deficit of some sort. You're having a metabolic derangement is occurring secondary to tissue hypoxemia.
Exactly. So the future is, as you take that technology in this case, it's in a large, electronic form, and you miniaturize that, make it very small, and you can put it on a smart watch. And now you measure the state of hypoxia constantly, not heart beat, not blood pressure. We're talking about the state of hypoxia for every person. So there's a constant monitoring of homeostasis and tissue health of the entire body.
Well, when you go and you look at, Dr. Majewski, you're probably aware of this. I know you are too. You go back and look at all of the previous work done by Schumacher on optimizing tissue perfusion and survival in sepsis based on oxygen delivery. And so, I can't remember the term that was used for that. What's the term that was used for that? I can't think of it now. But nevertheless, you want to hyper oxygenate the tissue. You need to give the patient volume. You need to get the patient's cardiac output up because it's all about DO2 and getting super high levels of oxygen to the tissue. But a lot of times with our normal parameters, and you have a patient that just looks kind of wimpy, you really don't know what's going on, but you give a little of this and you give a little of that, maybe you put a balloon pump in, and your blood pressure is okay, it looks okay. They're not failing right now, and that's a good thing. But is there something, are we really giving medications to satisfy our need for a number on the monitor that is a blood pressure, or are we actually visualizing the microcirculation where maybe that much Levofed isn't a good idea? Less, accept a lower blood pressure for better tissue perfusion may be the right answer. Now you have to have the pressure head, I understand that, but there might be something else you need to do because upping the dose of Levofed is only going to make the situation worse.
And what you have now, that device allows you to do telemedicine.
Yeah, that's another good point.
You now monitor the patient in any place, like ICU, constantly.
Yes.
And you know that where is the patient in advance to acute situation.
Not waiting till 6 a.m. for an elevated lactate.
Exactly.
Or an elevated, something else wrong.
From that perspective, the device, I'm not trying to explain how big is the device. I'm saying that's the future of prediction.
Yes.
What will happen to the organ and the failure. Simple as that.
Yeah, I think that's very interesting. Do we have the phone lines open? We never opened the phone lines. Yeah. Open the phone lines. And Dr. Majewski, if you could just open the phone lines in case somebody wants to call in. Do we have any questions on FaceTime or whatever that place is called? Do we have the phones open? Yeah.
Yes, we put that now.
Thank you. So we can keep talking for just a second. So obviously anesthesia would be interested in this device, Dr. Majewski. Cardiac surgeons would be, intensivists would be interested in this device.
Army.
Patients, the military would be
Military.
interested in on this device, of course.
Well, one very important group is the newborns.
Newborns?
If you have newborns, babies that are in the in the intensive care unit, the neonatal intensive care unit, the main issue is that the capability of monitoring these small babies is very limited because they are very small.
Mm-hmm.
Therefore, if you can, by looking outside on the skin, and that has to be developed, to put the probe on the, for example, on the forehead skin, and measure the EEG together with our parameter that we tried already in babies. We can glue or hold a probe on the scalp, outside, of course, not opening anything, just putting it with a very low pressure and continuously monitoring the skin. The skin will behave exactly as the urethra in terms of giving us an early warning signal what happened to the baby. Many times they have apnea event. Now you want to know what happened during the apnea and to alarm the team that this baby, no one is staying next to the baby all the time to look on the monitor. So if you have a bell that will ring you that says that there is some sort of drop in the score, the metabolic score, you run to the baby and you see what happened and take care on it.
Yes.
So it's a very important alarming system, and the market is very huge, and the need in these small babies is more significant and important as compared to adult patients because they have maybe other ways to penetrate to the body of this adult. But in the baby, you are very limited to go to, even to the blood vessel is very hard to go inside.
Mm-hmm. So I would like to, I do want to just ask you, and I thought of this here. So we have, very, I think, well established and understood vital signs, right? Heart rate, blood pressure, respiration. Would you consider this to be, this device, another vital sign?
Well, I hope that we have to prove, but I think that there is a very good potential that our index will turn to be a new vital sign that will actually will be complementary to the existing one. We are not going to replace any other methodology. The whole idea here is not to change the usual activity of monitoring, but to add a lower level, namely lower in the tissue level of events that we want to monitor. And this, for example, you mentioned using the microcirculation inside the mouth. That's measure just one parameter, but it's the same idea.
Yes. So you have the heart rate, blood pressure, respiratory rate,
and the hypoxia.
You have tissue
oxygenation,
tissue oxygenation score, or tissue perfusion score, or whatever you want to call it, index.
Tissue oxygen balance.
Tissue oxygen balance. Okay, I've got to get that right. I have a question from John Ingram. Other than inserting a bladder catheter, and I think you've answered it, but maybe you can elaborate a little more. What other means are you able to monitor other tissues, such as heart, etc.? Does the probe have to be in contact with the tissue if you're trying to monitor a specific organ? That's the question.
Okay, so I will answer to the last part of the question. Yes, you have to be in contact. The probe has to touch the tissue because we are using light that has to penetrate to the tissue, and the best way and the most efficient way to get enough light into the tissue is to have a good contact. Now, I have to mention that one of the wavelength light that we are using is a UV light for the monitoring of the mitochondria. And this penetration of the light is only efficient enough only when you touch the tissue itself. Mm-hmm. So actually you are limited. You cannot do it from outside the body. You have to touch the tissue that you want to monitor.
Mm-hmm.
Okay?
Unless it's a baby,
so
in which
you
case
can
the
adapt
skin
it.
is so
For example, let me just give one example, okay?
Yes.
If you have a patient that's having a kidney transplantation, okay, let's assume that we get a donation from a patient that died, and then they take the kidney out and preserve it and transport it within a few minutes or hours to the recipient patient that need the kidney transplantation. So you need to monitor this kidney in 4 different stages before you take the kidney out to make evaluation whether the kidney is good enough to be transplanted. We can do the test using our device. Number 2, you want to measure during the transportation, okay? It may take a few hours. You want to make sure that the kidney is not deteriorated during the transportation. And then once you do the surgery, by the end of the surgery, when you transplant the kidney, you want to make sure that the kidney mitochondria is functioning once you start the blood flow to the kidney after the transplantation. I was doing this kind of measurement in patients in Tel Aviv Medical Center years ago, and we found, for example, in one patient that they opened up the renal artery after the operation, and the tissue did not respond. I didn't see any change at the tissue level, although the large vessel was full with blood, but the microcirculation and the cellular level didn't get enough oxygen. So I told it to the surgeon, and what he did, he used some drug to take vasodilatation to the vessels, and then blood start to go to the microcirculation.
Wow.
So this is part 3. Then you can leave, in this patient, you can leave a small needle in the kidney for 24 hours and suture it to the kidney, and then it will remove automatically after 24 hours. But during the 24 hours, you can measure that the balance of oxygen to the kidney is normal and not deteriorating for some reason. Mm-hmm. So 4 stages in this procedure you can follow with our device.
And the kidney is pretty sensitive. The PO2.
Oh yeah, all organs. Now we are talking here about response time of seconds. Mm-hmm. Okay, for example, if you cut down the oxygen supply to the brain to 0, within 10 seconds or 12 seconds, you get almost 0 oxygen in the brain.
Wow.
So it's a term of seconds. Now, of course, if it takes 2 minutes, 4 or 5 minutes, you start to get damage. If it's more than 10 minutes, it can be irreversible damage sometimes.
Yes. Yeah. Well, probably more likely than not. I could probably go a long time. I probably could go 30 or 40 minutes, because I have a very...
You can go 5 hours.
Yeah, I have a very small brain.
We just scrapped the surface here.
Yeah, we have. That's a very interesting concept, very interesting.
You can
indeed.
do on that device, I would say, organ by organ. We have many experiments. We're talking about 50 years of experiment.
Yes.
And books and publication. We just, Avram did a review article, and the audience is, I'm happy we'll give him the reference and they can read about it.
Yeah, how can we get this information, by the way?
We will do a press release about it, about the article that was published.
I need to add that to this, though. Okay, so what I'll do is when you send me that press release, can we tag it to our video here later for people?
Yeah,
Patrick?
we can do that.
Yeah, we are a public company, so we need to do press release on those.
Okay, very good. Excellent.
Publicly traded company.
And then, okay, so, and what's the symbol?
B, like Bravo, India, X-ray, and Tango.
BIXT.
Yeah.
BIXT. Okay, very good. So we need that, and we'll add that to the tags on this video, Magic, when it's over. Listen, Dr. Majewski, I can sit and talk to you for another few hours, but in deference to you being so late, I want to thank you so very much for being kind enough to stay up with us so late. I'm going to have Dr. Platt start with the BXT25 nanoparticle presentation. If you would like to stay on, you're more than welcome to, but if you'd like to try to get some sleep, we would certainly understand that.
I will prefer to stay a little bit and listen to the discussion. Maybe I will be able to add if there are some more questions later on.
That's
about
excellent.
the drug efficacy measurement and so on.
Fantastic. We will. In fact, I do, because if you can do that, I would be so appreciative, because I want to know if you have studied. Now, I want to know if you have studied the tissue oxygenation index or balance, the tissue oxygenation balance with the use of the BXT25 nanoparticle. So now we're going to get into that though later. We're going to let you do your talk, and then we'll circle back with that full discussion. Please relax, and we'll pop you back on the screen after Dr. Platt is finished with his presentation. If you have anything to ask, just buzz in and we'll go to you.
Okay.
Thank you, sir.
Bye.
Okay.